Okay, well, welcome everyone to ABIN's monthly virtual webinar. This morning we have Dr. Lesley Manson, and Dr. Manson will be talking to us more about financing and return on investment and value-based care in the context of integrated behavioral health. We're so glad you're here. I am not going to give a long formal introduction because we want to make the most of our time. A couple of housekeeping issues. Please keep yourself on mute. If you do have questions along the way, please don't hesitate to put them in the chat, and Dr. Manson will be willing to answer your questions. Thank you for joining us this morning. And with that, I'll turn it over to Dr. Manson.
Thank you, Kim. Can everybody hear me okay? Wonderful. Thank you. So as Kim already said, if you have any questions, if you have comments, feel free to throw them in the chat box. You can also turn on your microphone right away and let me know, and I'm happy to respond, especially because as we move through here, there might be things that come up. If there's anything from last month that you have questions or concerns about, or something that's raised attention for you, please feel free to put that in the chat box as well, and I'll address it at the end, okay? So if you recall, I'm Dr. Lesley Manson. So nice to meet everybody again. And basically what we're going to do today is, last time we went over a few of the tools for financial planning. We talked about specific billing codes for integrated care. And this time we're actually going to go and dive into cost savings, return on investment, the equations, and we're going to look a little bit more into metrics related to value-based purchasing. We also reviewed last time more in detail about value-based purchasing, and this time we're going to touch on it one more time. Okay, everybody? And all of this is related to building fiscal sustainability. What we all want is to be able to improve the health of our communities. We want to make everyone happier and healthier, not only within our actual teams at our healthcare centers, of course, but also within our communities. But we can't do this unless we're able to keep the doors open, unless we're able to be fiscally sustainable. And in this day and age, we also not only need to be able to make money to keep ourselves moving forward, but we need to be able to demonstrate our outcomes as well. And that's where that value-based purchasing piece comes in very significantly. Okay. Last time we reviewed a lot and talked about integrated care, the basics. We reviewed those sustainability tools, and just to kind of bring it up again, we reviewed and talked about a pro forma. And I'm going to touch on that again today. But just so you know, there are some tools that will be posted after the end of this talk today, as far as the slides, but also some tools on how to create a pro forma example, okay? And as you move through, remember, everything we do needs to be pulled in. We want to pull it together, and they're all linked. That pro forma from last time, which is a visual representation, usually on an Excel spreadsheet, that's something that we can use to really be able to see what are our costs for our integrated care employee, for our program, for our healthcare center, what are the benefits, the money that's coming in, both in direct revenue, but also in things like cost savings. And then also on that pro forma, we have an equation at the end that says whether or not we're making money, we're in the red or the black, right? And then we can also add on a piece about return on investment. So that's what's really nice about these Excel files, is that it also does all the work for you, okay? So it pulls it all together for you in a very nice, clean picture. And we're going to give you an example of that in your resources as well, okay? So people can have something to look at and be able to work off of as well. I'm going to make sure all of the equations are built into the pro forma for you. So everything should be pretty linked, although once you start making changes, you have to keep up on making sure those links are accurate in the pro forma too. So now let's go ahead, excuse me, and dive right on into the piece of return on investment, okay? So in return on investment, there's a number of things that we really need to be looking at. Okay, which is similar to some of the aspects we talked about last time. We need to be really having a clear understanding of the roles and responsibilities of our healthcare team members, okay, the tasks that are at hand. We need to link everything to data points, because if we're going to really look at return, we have to know what we're measuring. So we actually have to have real data points to be able to determine that. We also might be looking at that as linked to very specific performance measures. And that's when it's really helpful, especially if we're going to be linking with anything like value-based purchasing. okay, is because if we have a true metric that we are obligated or reinforced to be able to meet every year, okay, then we really want to link it and look at some return on investment value with that, okay? And so we'd want to be able to know, what is that metric, okay? How much do we need to kind of bring in or do percentage-wise? What does that metric translate to, okay? And then what is the value of that metric as far as financially? Are we getting more incentives maybe per member per month? Are we getting a higher percentage rate at the end of the year as far as a return? Are we getting something where our general reimbursement rate, might be increasing by a certain amount, okay? So we'd want to look at that and place it into our metrics and our return on investment calculations, okay? And when we start to look at our calculations, there's two really important ways to look at it. One is through direct ROI, and the other is through cost savings ROI, okay? Is anybody in here concerned or interested in any other types of return on investment analysis? Just to kind of check in, there are other analyses that are available. These are the best and top two that most healthcare centers are looking at, okay? These are the ones that the healthcare centers are looking at and are important. Okay? I'm not seeing any commentary. So let's go ahead and dive into each one. And it's really important to be able to distinguish and know the differences between them. First is what we call direct ROI, okay? Just the direct return on investment. Okay? When we're thinking about direct return on investment, typically this is money in that of a service that we've done, okay? What are we doing that we are getting direct reimbursement from? Okay? It's as simple as that. What did I do today, this moment, that I'm getting paid directly for? When you can identify something where you're getting paid directly for, then you can do a direct ROI analysis on it, okay? So just to be very clear, that would be a very specific calculation. The calculation is gain from the person or the program, depending on how large of a calculation you want to do, minus the cost of that person or program, divided by the same number, the cost of that person or program, okay? So that's really important to recognize that calculation there. This is the calculation that is standard, and it's used across the world globally related to healthcare centers and determining ROI. If you go out and search on websites and look at ROI calculators that are out there for healthcare centers, they're all going to give you that same type of calculation. So it's nice to be able to have it. It's very easy, and you really want to consider that, okay? So again, it's gain from the integrated care person or program minus that cost divided by the cost, okay? And I'm going to illustrate it for you here in a moment. The next area is cost savings. Cost savings is a measure used to demonstrate basically the change or transition you're trying to make, okay? So it's when you're in a healthcare center and say you have integrated care and you go, hey, I've got this integrated care employee and I've recognized that I think I'm losing some money on this. And I want to switch out the employee, or the next hire, I want to do something different with them, okay? Or I want to maybe even, maybe utilize them in a different way to make up for any type of no-shows or cancellations I might be having. So I'm going to sit back for a second and think about and ponder all those ideas. And I might say, well, one thing I might want to look at is if I'm going to hire more integrated care employees, what's the best integrated care employee to hire? I might look at, how much does a psychologist cost? How much does an LCSW cost? How about an MFT, an LPC? What about a substance use provider? Okay. What about a promotora or community health worker? Okay. So I might start to consider the different types of providers that are out there. They're cost related. And I'm going to also consider, of course, my community, my population that they're going to be serving, and ensure their role is aligned. Okay. But as I'm thinking about that, I might use a cost savings analysis to determine the differences in the costs. So if I'm going to consider a psychologist versus a LCSW, I can look at a cost savings analysis. Okay. So I'm going to look at the differences between these two individuals and how much it might save me if I did that. Okay. If I changed how I'm going to run the program or what type of employee I might be looking at hiring. I'd also use this, as I said before, in kind of ways that we use integrated care providers. I might use it and say, in psychiatry, they are often one of the number one in primary care of the initial no-shows, okay? Not follow-up, but initial no-shows are very high for psychiatry. And we don't want them high, right? This is a service that is very difficult to access. We have very few psychiatrists, right? Or psychiatric nurses in our communities. And it's also a very costly service. It costs a lot of money to be able to offer that service, okay? So we don't want a lot of no-shows in this. So we might look at even the cost savings projected in having a integrated behavioral health employee that might be someone per se as an LCSW, a psychologist, a substance use professional, an OT, right? All these different types of professionals. We might use them to see the patient first before they see the psychiatrist. We might work it out that they actually complete the psychiatric intake instead, okay? Because it might be a lower cost if they no-show with them versus if they no-show with a psychiatrist. Because a no-show with a psychiatrist not only, right, takes away another appointment time, but we're also losing that cost, right? So it's very damaging, especially if you have a tight schedule there. So I might look at the switch. Okay, I'm hoping everybody sees that with cost savings, that's what we're looking at. We're looking at that switch. We're looking at if we're going to change something, what's our benefit to that? So those are the two ways that we look at them. So just to kind of do a quick quiz, right? If we walk on through here and think, how are the different ways I might be able to use return on investment and do analyses? The first way is I just want to do a workflow change. Keyword here is change. So I'd probably use a cost savings analysis, right? And workflows don't have direct money, right? Workflows are workflows, okay? Swim lanes, this person does this, goes here, does the next job. So if I want to change and I want to just even change the functioning of my front desk, I can actually do a cost savings return on investment analysis related to it, okay? Just so we see which calculation in specific we want to use. If I want to set the stage for the PCP visits, so in specific, one of the last times I spoke, I talked a little bit about how you can utilize your integrated behavioral health employee to go into and initiate a visit with a primary care patient before the primary care provider goes in. So say the primary care provider is running late, okay? They're running behind in their visits and their time, and the patient's already roomed. The behavioral health provider can go in and set the stage or the visit for that primary care provider. They can collect some data, information, maybe even doing some screening tools, identify any concerns, document all of this, and ready the visit. Focus the patient on those health goals that the provider wanted to speak to them about and the patient had in mind, okay? So they can set the stage for that. Now, if it's not directly billable, it would be cost savings, okay? Because perhaps in that role, that behavioral health provider isn't billing for that service. What's going to happen is the primary care provider comes in afterwards and uses that information in their visit, okay? Which means then the primary care provider actually bills for that documentation and that happening. And then you might optimize the billing on that. Because of that, they might be able to now bill a level 3, okay? Because they've actually identified more complexity and had more information to be able to utilize in the visit. So it's cost savings because that behavioral health provider going in isn't directly billing. Hopefully everybody's like going, okay, I get it. Huddles, cost savings, direct psychotherapy for your, and I use that term only because it's related to billing, for your integrated behavioral health employees, direct ROI, right? Because direct billing, direct. Medication adherence, cost savings, internship programs, cost savings, okay? Because oftentimes they're not billable, okay? HBAI, type of health and behavior assessment codes, direct billing again, so that'd be direct ROI. Utilization of team-based services. This could be direct ROI or cost savings, depending on if they're all billable or not. And then your COCM and CCM. It actually can be done in both ways, okay? Because there can be cost savings that you're really trying to identify based off of care management, and there's also some direct billing there, okay? So I'm hoping you're seeing which equation, because that's really important that you understand which equation to use, okay? So as we do that, we're going to be talking about these two, and I'm going to walk you through the equations so you can see how easy the equations are to utilize. And in addition, remember, I'm going to give a resource tool with a pro forma with the equation in it. And at the end, it just does it for you like magic. And so that's what's really nice about these tools that are out there, is that you can actually go on even websites throughout on US healthcare sites and go on there, put in your information, and does the ROI calculation for you. Okay, so just so you know that too, but I'll be giving you an Excel file with those, as well as some worksheets so you can do it yourself if you'd like. So let's go ahead and calculate a sample ROI. Okay, so I want you to consider naming yours, okay, whether it be in your head or maybe in the chat box. Think of someone that you would want to do a direct ROI on. And for all of you thinking about integrated care, probably one of those roles would be a behavioral health provider. Okay, so if we had a behavioral health provider, okay, one of the things that we need to do is kind of calculate their gain, right? Their income. We need to be looking at that. So what we'd want to do is we'd want to look at the number of billable patients per day, and we'd want to calculate that out. For this example, I'm just going to kind of normalize it and do like an average revenue generation, okay? But obviously, if you're going to do this for your own patient or your own patient mix and provider, what you'd want to do is pull your data. See for the last 3 to 6 months, who have they seen? How much money have we collected? Where are we not collecting and why, right? We want to pull the real data to be able to demonstrate that. But here, I'm just going to say, hey, we're going to use some variable coding, anything from initial visits, the 96152 coding, to things like 90832s, okay? And so just something like a 30-minute visit. And so I want to say the average revenue per patient visit is about $45. And you might think, wow, that's pretty conservative, considering some of you, if you're on any type of special contracts or federally qualified health centers, you're getting a much higher rate, right? Up into almost $200 and sometimes even $400 a visit, okay, at some of the very rural sites. So just depending, obviously this number can, quadruple on up as far as how much money you're earning. But we're going to stick with something conservative right now and say just $45. Then we're going to say that you actually have identified some high complexity and have brought in an additional $60 per day with some of the work you're doing. And we're going to say you're working about 18 days per month. That's fairly regular, okay? And we're just going to do, for the sake of simple calculation, that there's 12 months in the year, okay? So just kind of working that out. So that next step would be to calculate the cost of the provider. Now that we've kind of calculated a little bit about what their income would look like. Now we're going to say the cost of the provider. We're going to say that their annual compensation and benefits is about $88,000, okay? And so this is going to be the benefits and their compensation package, okay? So after we know that, and that's something you can get from your HR department, okay? You can also kind of guesstimate that if you know your employees' costs and potentially kind of what your costs are as far as your benefit package. You can estimate it a little bit. Then you're going to look at the percentage of the ROI and the results. So I'm going to take you through that. So here you go. You can kind of see the mathematics laying out again. Very simple example, right? So they're going to see a few billed patients every day. They're going to go about 18 days a month. We're going to multiply that by 12 months. So you've got about 90,000 in revenue. And that cost, member, as I said, is about 88,000. Okay. So obviously you see there's a difference in price. Okay. So then we're actually going to do the math. And if you see in the middle of this form, you see the 90,000 subtracted, okay, with by the 88,000. Okay. And then you've got 2720. You divide that by that same number again, that cost again, that 88,000. And you're going to get 0.03. You multiply that by 100 to get your percentage, just like we do to do percentages in general. And that's a 3% return. Okay. So every dollar you're spending on the behavioral health provider to be in play and practice at your organization, you're actually gaining an additional 3 cents. Okay. That's a very solid ROI. Now, your ROIs could be anywhere, again, depending on the rate of reimbursement you're receiving. Remember, we were pretty conservative here, about $45, okay? If your rate of reimbursement is higher, obviously you're going to have much higher rate of return, okay? You also might say, oh, well, we pay a lot more and our benefits cost a lot more. So you might have higher costs related to that as well. So if that's the case regarding it, then obviously you might have a little bit low of a return on investment. But it's really important to do this calculation especially if you're an integrated care leader, a director of service, or even an integrated care provider yourself, just to sketch it out and see where you sit. I don't know how many of you have experienced this, but I experience it often. I have experienced it within my time as a behavioral health provider, okay, as a manager, as a leader, director, and then as an executive officer. I experienced it all the time. The same adage of integrated care, behavioral health, they don't pay for themselves. It just costs us more money, okay? People like it, like programs, but it costs us money. If you start to actually do the calculations, you'll be able to recognize, do I cost you money, or am I actually bringing you in a return on investment? It might be low, but I have a return on investment and I need to start to identify it, okay? And it's really important to be able to have that to leverage as far as, especially in negotiations for yourselves within your own healthcare centers, but as a healthcare center in negotiations with your payers and your communities to be able to say, this is what's really happening here, okay? And so I'm going to talk a little bit more about that in a little bit. So the other things, I gave you a really simplistic view of how you can do this calculation. Obviously, there's lots of additional income you could consider. So there's many roles the behavioral health provider has. And one of the things on the last webinar I spoke about is really getting that job description and going through it and linking and building a pro forma that has those tasks associated. You'd want to consider that in your return on investment analysis, because you can do the analysis, the return on investment analysis, from the pro forma you develop. All these tools link together, okay? So you might find that, hey, my behavioral health provider has another task. They also do this. And by naming that task, you can be able to determine, how do I identify the financial reimbursement or incentive that this person is providing, okay? And if any of you have ideas or questions about that, please put them, because I love to hear those. And I love to be challenged by, my behavioral health providers do this, and it's not, there's no money associated. How can we justify, or how can we create some sort of demonstration that that's worthwhile financially for them to do? So put it in the chat box if you can think of any of those, okay? So we want to look at additional income that we might be missing for things like that. Maybe it's groups, setting up those providers and helping those providers out. Okay, screenings, that's a great one, Dr. Gibson, great one. So I would look at the same thing with that. So on screening, sometimes we can bill, sometimes we can't. And it really depends on the action that's happening afterwards. And even if we do bill, it's a very small amount, okay? So with screenings and mental health, it all depends on when you're utilizing them. So one of the first things I might do with that is I might consider kind of my workflow on that of, if I'm going to implement this new tool within my integrated care health centers, when am I going to do that and why? You know, right? When is it going to be the most beneficial that I can actually receive financial incentive? So in behavioral health appointments, it might be initial appointments. So that's gathering some of the information needed for the general visit, okay? And for my primary care visits, I might actually link them with very specific visits. Okay? It might be physicals, it might be, you know, specific annual exams, sports exams, etc. Maybe specific stages for our pediatric populations, and then add that to the billing. Okay? Some people do universal screenings and are doing it multiple times for patients, for all patients walking in the door, but then we're not able to always bill for those. Okay? So those things are going to go into a cost savings analysis, right? Because they're not billable. And what we're going to want to do is consider on that, what is the objective for our screening tools? What is the real reason why we're doing it? And what is it tied toward? Well, I'm wanting to identify these specific populations and their concerns. And then why? Because it's linked to what? They're all linked to actually very specific metrics, which is why we utilize them, right? And we're actually told by, what is the big UPTSPF? The United States Preventative Task Force, right? So we have these very specific items that we need to be screening universally for or periodically for. And so we're going to want to look at that and say, what is it tied to as far as our specific metrics and reporting values? And those have a financial value attached. If we're in a very small clinic, then we might not have much financial value attached, because we might not be eligible for those larger kind of financial incentives because our population is much smaller. We just don't have the numbers of patients that other clinics do to be eligible for that. In which case, I'm going to look at just the value of being able to have identification and being able to link these people to services more immediately and look at, is there financial incentives or values that are coming in from that? Am I receiving more internal referrals based off of that? Am I providing more referrals to other community-based organizations that I can link with and say, hey, community-based organization, I'm going to be providing you some referrals. And I'd like to do that on a larger, greater basis. If we do that, what are some things that we can do with exchanges of services? Again, what are some incentives that we can work on that we're actually helping the population together more effectively together? Okay, so we'd actually start to look at these specific pieces. Okay. Robert says case management services, resources, brokering to address SDOH needs. It's a great example. In some states, wonderfully, they've actually already jumped to a direct ROI on that. This would be a, this would not be direct ROI unless in your state, which I don't believe you have actually a financial value. In some states, they've actually identified if you are receiving Medicaid financial support and you're identifying social determinants of health through very specific types of questionnaires that they've deemed appropriate, you're documenting it appropriately, that you actually receive incentives financially for doing that. So there's direct ROI there, okay? If there's not for you and your organization, then you're going to want to look at how that's helping the community. We'd be looking at internal referrals, but mostly for this one, we're going to be looking at how it's going to be linked to our interventions we're going to be doing and what are the best interventions at the lowest cost that give us the greatest outcomes, okay? That's always the case, right? We don't need to pay really high costs for something that's not going to have the greatest value, right? We want to really look at that. SDOH is one of the best ways to do that. There are actually sample organizations across the United States that have done projects specifically on this, okay? Robert Wood Johnson Foundation actually ran and supported some kind of this value-based purchasing kind of a piece through these grants that they were giving to say, if you were going to do this and assess, how would you determine there's an incentive financially for you? And what healthcare organizations, it was mostly FQHCs and community health centers, they actually went out and did assessments and found that their population needed specific groceries and food. They had no food resources available to them. They had, I believe it was like Circle K's, 7-Elevens, I'm trying to say like a more kind of these stop and goes, and no real grocery stores, so no access to real food. So what these healthcare centers did was they put freezers, small freezers there. They actually received grant money from Robert Wood Johnson, put small freezers in there and actually loaded it with chicken and frozen veggies. Okay. The chicken and frozen veggies, if you don't know, are pretty significantly low cost. And when you deal with a manufacturer, you can get it for very low cost. So they were able to get it, I believe, at less than $1 a bag of veggies, which normal vegetables can cost $1 for a bag in frozen supermarkets. So they got it for a little bit less than $1. And then they also got their chicken breasts for less than $1. They stocked it and sold it. And then they tracked the healthcare outcomes specifically of their populations with diabetes and related to weight, okay? And so they did a very strategic, okay, and very tracking cost outcome with that. And they were able to direct their specific populations to go there to be able to actually get food, okay, at low cost with, reasonable health. And they were able to recognize that that intervention that was supported by a grant and didn't cost them anything, but they did still work out the cost of a freezer and these pieces, okay, was very minimal as far as cost with the outcomes of their patients with diabetes being able to actually have improvements in regulations, okay? And they actually saw a weight reduction, okay? So it's really important to consider, it's taking the time to brainstorm. What does that look like? Why would I need to do that, okay? And what are those outcomes that are associated? So it does take some time with it. Let's look at some cost savings examples. And then I want to wrap it up to really looking at that value-based purchasing piece, because we're all going there. And even with that example of the freezer, right, in a Circle K, that's actually now longstanding in those organizations that did that. They actually made a deal with those Circle Ks, and I'm using these terms like loosely, 7-Elevens, right? They actually made a deal that they would keep it and stock it. And so they ended up keeping it and stocking and they set the price at, again, they couldn't go above $1. And so they set that price and kept it lower than $1 for both chicken and for the frozen vegetables. Okay. And so By the way, that 7-Eleven or Circle K still made money because again, the cost of those is significantly less. Okay. So they still made money and value. So it was a win-win for everybody and the community. Okay. So there's lots of ways to do this, but you do need to brainstorm. The easiest way is when you have a direct association to a metric that you want to change and a value based off of that. Now let's look at the steps when we want to consider our savings. So any type of change or idea that we might have, okay, that we really want to show and demonstrate, okay, I'm thinking about switching this out for that. It's almost as simple as I want to switch out this expensive paper towel for this cheaper paper towel. Is it worth it, right? Well, it might not be if they're not really very good, right? And so it's the same type of thought process and workflow, okay? So when we're going to do this, I'm going to show you two examples. One is a psychiatric provider switch and a pediatric provider switch. Okay, these are actually the two most common ways that integrated care sites throughout the United States actually leverage their integrated behavioral health provider to provide a different level of care and reduce their costs of services. So in one way, we're going to look at this piece where you have a psychiatric evaluation, that initial appointment. Remember, as I said, it's one of those appointments that actually has one of the highest, okay, no-show rates, not the follow-up appointments, but the initial. And that's really, complicated because this is also our highest cost employee at a healthcare center, right? Our psychiatric consultant is typically our highest cost employee, right? So if you're going to do that, we want to really look at that and say, okay, do I have a problem with this? And if I do, what can I do to resolve it? I need to make my psychiatric provider still happy, right? And I need to make my community happy still, right? I still need to be able to serve both needs if I'm going to do a switch out. So what community health centers have done across the United States and other ACOs, et cetera, what they've done is commonly is leverage their integrated care provider to ensure that they teach them exactly what the psychiatrist wants for an initial intake evaluation, okay? And there's a code for that. So if the psychiatrist isn't doing it, there's a duplicative code for the integrated care provider to actually do it, okay? That's at 96152 instead of a 96151, okay? So the behavioral health provider can do it. So here you see the psychiatric evaluation appointment, okay, their cost. We see that, okay, how much does a behavioral health provider cost? And if they were do it, and we're just going to do some quick and easy dirty math of, hey, if the behavioral health provider does the intakes instead, what is going to be the switch out? Because if they did it and there's no shows, that's what we're going to be saving, right? Because we're saving money from the no-shows of the psychiatric provider. And with an easy calculation, again, this is easy math here. Your math might be a little different because you might be your psychiatric provider might be costing more, et cetera, okay? So with easy math, you can just see it and be able to do it very easily. And you see there's a 58% return, okay? That's a 58% savings in cost, okay? So looking at very easy math, but just to know, this is done every day in the United States to resolve this concern. If you have this concern at your organization, you might be wanting to consider this, doing a little bit of a switch out, okay? An ROI example number 2, okay? Here's another example. This is a pediatric provider. Now this is being done across the United States, again, very commonly in federally qualified health centers, community health centers, ACOs, et cetera. And this is actually when in pediatric care, in your pediatric appointments, when there is a lot of general pediatric stages of care appointments that you might have, okay, that you might look at that and say, hey, for most pediatric appointments, there's a lot of behavioral questions, okay, and behavioral evaluations that are being done, right? So at 1 year, 2 years, right, going up the stages, you have a lot of that. So there's a lot of that also psychoeducation that is mandated and required to be done in your pediatric appointments. So if you look at that, you have to consider, if we're in a team-based environment, does the pediatrician themselves need to do that psychoeducation, or can anyone do it? In fact, anyone can do that in the healthcare setting. So lots of healthcare centers have actually switched out for nurses or other types of employees, healthcare team members to do those specific pieces of the pediatric appointment. So they come in and do all the initial questions, screenings, the psychoeducation, right, of, why we want to use certain bottles, why we want to drink more water, right? They do all of these things, toileting, right, parenting pieces, behavioral pieces. So they switch it out and do it. And the pediatrician comes in at the very end, okay? Now, a lot of pediatricians love to do this type of education, but it's really about the value and where they can be highest utilized. One other way you can do it is switch it out and have your behavioral health provider do it. It gets them more with the pediatric population. Okay. They have more exposure to them. They will also really enjoy it. They're also going to come out with the highest amount of referrals with the pediatric population as well. Okay. So you'd have them go in and actually do that subset. So you'd switch them out and have them do the kind of screenings, the early identification, and all the psychoeducation that is involved with the initial part of those appointments. And as you see here, again, the mathematics are calculated for you. And so it's the difference between having the pediatrician do this for the whole day. And if you see, it's only 1.5 hours for the day, just kind of marking out this amount of minutes from each appointment every day. Okay. And so what's the savings in the end? So if I'm being conservative with it's only 1.5 hours, it's about a 10% savings if we switch it out. At the same time, all the healthcare centers that have done this have actually said, yeah, sure, there's a cost savings. But really what we're getting is higher referrals to our integrated health employees. Our behavioral health team is actually skyrocketing as far as our referrals for our pediatric care and population. Our families are coming in more with questions and working directly with our behavioral health team, much more than they ever were before. And our pediatrician feels much more supported by the team and actually has more time at the end of the day. And what are they going to do with that time? Whatever they'd like to do with that time, right? Maybe it's catch up on documentation. Maybe it's see another patient or two, right? Or maybe it's something else, okay? But it's really important to consider all those other benefits of this as well. If I added in that extra cost of them seeing another patient, I would be boosting up my costs, right? Or my income, right? There's other things we can do cost savings on anything. As we noted, we can really look at SDOHs, we can look at screening. It just takes time to map it out, okay? I actually did a nationwide huddle ROI for a CMS. And so the Centers of Nursing Excellence and CMS received a grant and said, hey, what we want to look at is the medical neighborhood and how that's being rolled out across the United States. And one of the key essential elements of that is the huddle. Is there an ROI on this? And so we actually studied hundreds of centers across the United States and actually looked at the huddles, evaluated them, and then worked on the actual huddle tools and how to incorporate that within the healthcare centers to actually have a better, more effective and efficient huddle that's very specific and time-based, right? Like 5 minutes, you've got all your patients for the morning or for the day, you're done. You've actually used a very specific huddle tool that's even on paper or through your electronic health system. So you've mapped out who needs to do what very specifically that have aligned with your care and resources and your SDOHs to refer to maybe more case management, et cetera. And in states that have case management, that's a direct bill for your SDOHs, right? Okay, if you have case management billing. Okay. So we look at this huddle, all of this was actually done and calculated with rolling of actual minutes that people talk to each other. And so how the study was done is at first viewing all these hundreds of sites is we actually just time cycled. So we literally with a stopwatch timed when you talked with your MA about what you were going to do today. Okay, everybody, this is what I need. And then, you left and saw a patient. The provider comes back, talks to MA about what they need to do for the next patient. And then they said, oh, make sure you let the lab know. The MA walks over to the lab, told them what they needed for that patient. Again, every amount of item of communication that could have been done in a huddle was time cycled. Okay. And then brought back. Does this make sense? Everybody's getting how it was done. Okay. So that was all done. And then of course, there's the amount of time and cost needed for training people later on how to actually do a huddle. What does it mean? And then putting the tools in place to do that so it can be done effectively. Okay. And there's actually huddle tools. It's all published now on AHRQ. Of all the information that has been done from all of those things. So that you'll find the huddle checklist is on there with calculations. I actually have some of the check sheets that we made, and I believe those are still up. If not, feel free, Dr. Gibson, to reach out to me and I can send them. Okay. So these things are out there for people to use, but if you see, you just kind of walk through it again, looking at all these pieces and costs. And in the end, there's actually a huge cost savings. Very surprising. And truthfully, a lot of people at first thought it wasn't going to happen. Okay. But if you actually do those huddles effectively and efficiently, there's a huge cost savings. And when you consider how much communication we do throughout the day momentarily, go do this, go to that. Oh, I need this for the next patient. You can see if we did it all in a specific amount of time, okay, that there's going to be a lot of value to this. Okay. So there's lots of ways we can do this. I'm going to skip through these last ones, but I'm keeping them on the slide so you can see. Again, we always want to challenge everybody as there's always additional income and additional costs we need to look at. How large our equations can get will depend on how much you can consider as far as costs and income with a different scenario, right? So we can look at the costs and just consider how much of an employee costs as far as their hourly rate. And that's how we look at it. We can look at very specific costs of even making the change or even considering doing an equation. Well, the time I'm taking right now for the 5 minutes to write out the equation, that's a cost. That's 5 minutes of my time, right? We can be really picky about how much costs we put into an equation, okay? And it's really up to you. But there's lots of benefits to consider in integrated care, okay? And we really want to consider all of these areas. In every single area you can do an ROI on, whether it be direct or cost savings. And if anyone wants to really consider you have something in specific and you say, I want to go for a grant, or I'm really wanting to sit down and negotiate this for a value-based purchasing piece, or I just want to look at it in my healthcare center, I'm more than happy to donate some time and give you some brainstorming on what that looks like. Okay. I do it all the time, so it's pretty quick for me. And I teach these courses a lot at doctorate level in multiple colleges. So there's a lot of emphasis on name it, and then we actually walk through it all. Okay. So there's a lot of value in this, and especially in your health centers, if you ever really want to be able to demonstrate and say, no, this is the true value. This is where we stand. And no more of the adage of, we aren't a return on investment. We are. And this is how I've demonstrated it, right? You also want to consider all the different types of costs that can incur in all of these pieces. And that takes a lot of brainstorming too. Okay. I'm going to show you here. It's really hard to see it, I know, but this is another one of those pro forma examples I showed people last time. Okay. And I just inserted a picture. But if you look on the very bottom where all the color coding is, okay, if you were here last time, maybe you kind of see like this looks familiar. This looks like a pro forma. In the bottom boxes, you see there's total revenue, costs and expenses, calculation of the total revenue, and then there's a return on investment. And that's the analysis being done for you in the equations. So I'm going to give you this actual pro forma. Okay, I'm going to fix it up a little bit for you all, and I'm going to give you it as an example. So all you need to do is go in and delete the things you're not doing and put in the values that are important to you. Okay, the cost of your employee for integrated care, maybe the value that they're receiving as far as their income, etc., for the visits they're doing, and you're going to get at the end it all done for you. Okay, your pro forma evaluation and whether or not you have a direct ROI. So this is a direct ROI example for you. Okay, and I hope you all consider using this. Okay, so last time, to tie all this in, why are we doing this? Yes, you can certainly do this just to stand on its own, related to knowing your financial sustainability and building it. Okay. But the reason why we also want to start to look at this is we want to start leveraging it for value and incentives, because we're all moving toward value-based purchasing. Last time I reviewed the foundational tenets of value-based purchasing. And if you remember, there's two areas. One is performance measures, and the other one is financial incentives. And the tenets have these specific areas involved. So I'm just re-highlighting them again. And it's very important to know these, because as you're sitting down and actually brainstorming or starting to build value-based contracts, which you all can, you can be the voice to do that. You'd want to know all these and align your integrated care providers and programs with the foundational tenets. Okay, that's very important. Okay, so here's your financial incentives for the foundational tenets. So what these mean is that as people are building their value-based performance and purchasing contracts, they're going to look at each of these areas. And these are the areas that need to be involved in them. That's what it means. So in financially, these are the areas that they're going to look at, right? And performance-wise, these are the areas that they're going to look at. Okay, just to kind of go back and forth for a moment. And again, we spoke about this all during the last webinar. Okay. Now, what it kind of looks at, there's this stratification that occurs, and there is a lot of risk. And for healthcare centers that are sitting at the, at the table, you want to really look at where your risk is, okay, and where it's going, so you can really start to consider making it something that's going to be your value. Okay. Now, there's always a flush out related to what it looks like, meaning it's never always value, okay? Not yet. Maybe in another 50 years, we might get there, okay? But right now, there's always this equation of a little bit of a percentage of fee for service still happening, some shared savings that might be happening, and population payments. And I'm going to go into that here in a moment. Again, this was all shown at the last webinar as well. But how it's all tied, basically, and how we're demonstrating is all through metrics and measures, right? In the end, that's what we're looking at. Because yes, do we want a healthier population and community? Yeah, but how are we going to be able to demonstrate that and prove that is through our metrics and measures. We have to have real data. We have to be a data-driven healthcare center and team, okay? So I touched on this a little bit more last time as well, but I'm going to go over it again here a little bit deeper and show you some examples too, okay? So we want to be able to know our metrics and tie them in, and we really want to also be able to name them ourselves, okay? There's many ways you can look at your metrics. This is just a slide, and I'm actually have this slide again duplicated later, listing out some of the areas for measures and metrics, okay? If you are a healthcare system and you're in management, you might be really familiar, might go, oh, NQF, know it. Oh, HEDIS, I see that, right? Know it, UDS, okay, NQF, right? National Quality Forum. All of these are areas that you'd look at for metrics, okay? You might say, hey, I also have substance use. I'm a standalone mental health facility, Joint Commission, JCO, right? So there might be places that you go, oh, I'm a hospital, okay, right? So other metric areas, but there's lots of them. And if you're a specialty area, you have your own guild metrics that are associated that are actually linked through these, and they have their own. So I gave a specific example for asthma and immunology, as they have their own specifics. And just to kind of let you know, they actually have their own team-based integrated care metrics as well. I did a keynote for the American College of Allergy, Asthma, and Immunology related to specifically that. So our population health and team-based integrated care metrics for that specialty. Okay. So believe it or not, okay, dental has them as well. Okay. So our specialty also has very specific metrics for integrated care. Okay. And how we can leverage behavioral health providers in that. So we want to go to those. We don't want to make up our own metrics, although you can. The best place to do is go to the metrics that we know are already being utilized. Okay. So we want to think about our metrics. We want to consider model fidelity metrics purely so that we can also recognize and have the highest and best value for the integrated care that we're providing. We know if we want the outcomes, like I said last time in the webinar, that our integrated care model says it provides, we actually have to have some fidelity to the model in some way, right? So we might want to have some model fidelity metrics, okay? We also want to look at our organization and how it's running and being able to support the people inside of it purely as that quad aim piece, meaning quadruple aims, and what Bodenheimer says. And what we know the adage is, we need to make our team healthy in order for them to be healthy with our community, right? So if our team is dysfunctional, then we might not be able to provide the best care, okay, at the most effective and efficient way, right? So we might want to think about our employee wellness, satisfaction, things like that, which we know are tied into our ability to be effective in healthcare as well, in delivery, okay? So this might be something that we're going to be looking at too, okay? We're also going to look at our clinical metrics because that's the highest tied to value-based purchasing contracts. And in a little bit, I'm going to talk a little bit about the examples across the United States and what people are already doing for value-based purchasing contracts for integrated care in specific, okay? So we want to look at clinical metrics, and we want to look at this because it's really that demonstration again of our health for our communities. And this is proving that what we're doing actually has an impact. So we can look at all these different types of areas. And again, we'd look at these and we'd go clinical metrics. Now I'd go back to that other slide, okay? And I'd go, let me look at, do I have to report to NQF? Okay, do I have to look at HEDIS metrics? Do I have to report with JCO, right? What are metrics from there that they already have established? which ones are clinical, which ones might be related to model fidelity, which ones might be related to organizational. Okay, so you'd want to align them. Okay, just so you see that. That's how we're going to make these decisions. Okay, there are those standardized metrics we all are going to align, again, just kind of giving that to you again, because we're already reporting it, right? So if you have your Medicare, right, QPP, we're already doing it. We have to report these metrics anyway. We want to align with those. When we're doing metrics, what tends to happen, and you can build this into your pro forma as well. Like people are like, oh no, that thing just keeps getting bigger. Okay, the pro forma or your Excel document can actually do your metric evaluations too. What people don't realize is sometimes they think, oh, it's just a reporting metric. A metric is a metric. We have to do X. And I'm going to show you some examples here in a moment. But it's actually a mathematical equation. Metrics are used because there's a mathematical equation attached to it, which demonstrates value. Okay, so the mathematical equation, I gave it to you at the bottom. This is what we use. Okay, the numerator is a piece of the metric, and the denominator is the other population piece. Okay, so if you look at that, this, just so you know, every metric you can do, you'd want to actually build this in to an Excel file, or actually in your EHR. Sometimes it can do it automatically, depending on your EHR package. Some of the PHM EHR packages or population health packages actually do the equations for you, which is nice. So you get an easy read instead of looking at a bunch of numbers like, oh, wow, I've got a bunch of stats and data on my population. It actually translates that data specifically into an output of a percentage. Are you doing a good job with your population with this mathematics? Okay. So I gave that to you. This can be built in as well. Okay. But it does take that data pull from your EHR. Okay. So unfortunately, I can't give you an easy one to do it because it needs the data to be able to do it. I do have a list of metrics, and I've illustrated out for an MAT program. I think it's about 20 or 30 of the mathematic equations of what it looks like. If anybody's interested in what that looks like, I'm more than happy to show you, okay? But it's just illustrating a metric and then showing what the numerator and denominator is, right? And then it's just a matter of data pulling and doing the math, right? Division. You always want to think stratification within all of these. And what's happening across the United States with value-based purchasing, okay, is in it, what we really are trying to do is we're trying to demonstrate that we have the highest value, okay, at the lowest costs. So we're trying to demonstrate that our healthcare center keeps the doors open, that we're all happy and healthy inside, and also our communities are actually improving in their healthiness as well, right? And hopefully happiness too, okay? So across the United States, there's already value-based purchasing contracts that are out there from insurances, also from what is not an insurance company, but brokerages or membership services now for healthcare centers, which are actually growing in popularity, where people they sign up for a health membership and they get certain types of visits covered by their monthly cost. Okay, it's not like real full health insurance. It's a little bit different. Also, Medicaid plans have actually already developed value-based purchasing contracts for integrated care. And then specifically what I'm talking about is for healthcare sites to actually embed some way of model fidelity of integrated care. So they have an integrated care behavioral health provider, maybe doing primary care behavioral health. Maybe they have CCM or COCM. There's specific requirements for this, okay? So outside of that, choose a model and name that model, okay? Then they look at the very specific pieces of, okay, what's our value-based purchasing? The first piece they're looking at is our clinical quality metrics, and then they also look at population health. Now they look at it very specifically. They need to be looking at it through the lens of who their populations that are the highest cost for them. Okay, for Medicaid, for the health insurance, for whoever that community is or that payer is, they look at that. Because honestly, they have to. They need to get those folks who are at the worst as far as their health to get those outcomes, right, improved, because those are also the highest cost for them, okay? So the most common metrics are gonna be things like PHM metrics are going to be things like the depression metrics, believe it or not, your PHQ-9 metrics. So if you, one of them is depression remission at 12 months, Okay, most common, it's like a PCMH, NCQA, NQF, UDS, and a HEDIS metric. Okay, remember a lot of these larger metric are commissions, share metrics. They all have the same metrics. So there's actually a very large commission that reviews all the metrics from all these organizations like JCO, et cetera. And then they go, yes, this is the one that everybody should use or we support. And then a lot of them pick them up. So there's shared metrics throughout all of these different areas. Okay. One of them is depression remission. And that's a very high common one that's utilized in value-based purchasing. And so what that is improving a specific X% of depression remission. Okay. So PHQ score, that's how they demonstrate it. So you see, have a PHQ 9 score of 5 or less, and you want to look at that at 12 months. Okay. And so that would be for all your patients that perhaps had 9 or higher. That's the typical metric. And again, this is again, a very high percentage of contracts have this, and it's a very common metric. Okay. So that's the most common metrics, just so that people know that's out there in those contracts. Outside of that, then you have your PHM or your one, which is really looking at what is that very specific population and helping to improve either access for those populations to see the behavioral health provider or improve some element of their health and functioning. Sometimes it's a functioning metric that they can do, and sometimes it's a health screening, going back to those clinical quality metrics. But it depends on the population. The population could be individuals who are determined to be have severe or significant mental illness. It could be individuals who are determined to have IDD, intellectual developmental disabilities. Okay, it really depends on that Medicaid system right now, and what you're picking up as far as your community. Sometimes it depends on zip code. So in some areas of Arizona, it's actually determined by your PHM metric is determined by your zip code, and it's determined by the zip code health. So if in that area hypertension, let's say, or diabetes is higher, then they're looking more toward the diabetic metrics. And so what you'd be doing is saying my integrated behavioral health folks are going to be seeing my population that has diabetes, and they're going to be seeing them to actually do these specific things. Again, you're going to see cross-reference of depression, lowering them for patients who have diabetes comorbidly. And then they're also looking at diabetic distress often, okay? So if you don't know, there's specific diabetes scales, the DES, the DSS. So there's specific scales that people use to demonstrate improvements in diabetes for specifically behavioral health providers, okay? And so those are always great. So those are things that they're using, okay? They're also using quality of life functioning measures and scores, and that just depends on the system, again, of which measurement tool, whether it be something like from the Promise, whether it be something like a Duke, whether it be something like a quality health measure from the CDC, okay? It really depends on what you negotiate and what that system is doing, but that's another frequently used measure, okay? Another measure that's used is related to cost of care. That's simple. It's ED visits across the board for most of these contracts. Just so you know, it's pretty easy. That's one that every contract that I've seen also has that on. And they're looking also sometimes at specialty care at some of them, but always all of them have had emergency care visits on there as well. So reducing that or improving their ability to go into primary care right after that. And those are already established metrics as well. So going back to those standardizations, okay? The another one is looking at the screenings and access and penetration rates. So in specific, they're just wanting your integrated behavioral health employees to have access, to be seeing more patients and to be seeing very specific areas that they believe are needed. So you being able to say, hey, we are seeing X amount of diabetic patients. Before we saw 0 or 2%, and now we're at 50%, okay? Or patients who have IDD or patients who meet blah, 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 okay? I'm going to show you some brief screens on metrics. I don't think it's worthwhile to read them all. You're going to have access to these slides so you can go over them, but this just shows you some ways and some already established metrics that have been built into some value-based purchasing contracts, okay? There's operational or those model visits, okay, because they want to know, okay? Sometimes they're episode of care visits, and those are attached to your hospital settings as episode of care visits, okay? Sometimes it's the penetration rates. Okay. We also are looking at experience of care. Okay? So we want to look at that. And you can see those, usually people use the national surveys and data, okay, with that. And again, they're all tied to integrated behavioral health. Okay, just so you know, everything that I'm talking about is tied to integrated behavioral health. Okay, cost of care, again, the ED visits and usage, as I noted. Okay, there's other ways to look at cost of care, so I'm just giving you those. Okay, but again, the most common in all of the contracts that I've seen and consulted for thus far has been the ED visits. Okay, and the state Medicaid contracts have all been that too. Okay, and then those access. Okay. So again, we want to be able to do this, but I also want to say and put a shout out, I know I've got to end here, is you all can be that influencer for value-based purchasing, for change, okay, to talk with your community, your healthcare sites, and to talk with payers. You can be leaders in this. You can advocate for policy-driven change, your metrics to be able to be built and sustain, and be able to demonstrate your value. And you can be the one to say, use these metrics, and we're going to be doing them here. You can have them meaningfully understood within your healthcare center and utilized. Okay. So I know we don't have a lot of time for questions. I do apologize for that today. I wanted to end a little bit early. I just didn't. But I want to thank you for all of your time. I'm going to stay on for a moment if you have any other questions, but I know you probably also have to hop off. So thank you, everybody, for this kind of run through and these brief touches related to ROI, value-based care, and our metrics for integrated care. Okay, so thank you, everybody.
Thank you, Dr. Manson. That was an amazing presentation. And thank you for all the wonderful tools and resources that you have given us. We will be sending out, or we'll actually be posting the recording of this and the resources to our website. So please check that out. Any last minute questions? Please stay on if you do have some, and if not, thank you for your time today, and we'll see you again next month.
Thank you, everybody. Bye-bye.